Hi, welcome to my podcast. My name is Dr. Brendan McCarthy. I am the Chief Medical Officer of Protea Medical Center in Tempe, Arizona. Thank you so much for tuning into my podcast. Welcome. Today, we're going to get into some more Q&A, some more questions that you guys have brought to us over the past series we did. And this comes from that series we discussed on progesterone, and those of you who are reverse responders to progesterone and the impact of when you take progesterone, your body responds completely different than you're supposed to. So before I jump into these answers, if you'd like, please take a moment and find the subscribe link and subscribe. And if you like the material we are doing right today and you find something in here being helpful, please press the like button. If you know someone that would benefit from the work that we do, or just from this content you're getting today, please share it. With that said, let's get into the material. Again, we're talking about progesterone and reverse responding to progesterone. What does that mean? When someone reverse responds to progesterone, it's when they take progesterone and instead of feeling that benefit with sleep, with less anxiety, with just overall sense of feeling more calm, they feel the exact opposite. It's like they take crazy pills, as one woman described it to me. The thing is progesterone in a normal cycle, it's dominant in the second half. And it's the thing that when it's low, that's what causes women to have PMS. What are the symptoms of PMS? The most common neurological ones, it's like brain chemistry ones are going to be a lot of anxiety. You see depression, you see insomnia. Sometimes you see headaches. These are all neurotransmitter-based symptoms. And that's because when progesterone crosses the blood-brain barrier, it gets converted into allopregnenolone, which is a potent neurosteroid that plays a role in the amygdala in modulating your response to the stressors in the environment around you. So progesterone is just a key part of your brain chemistry. It's a very important part of you. And when a woman doesn't ovulate and she has low progesterone in the second half of her cycle, and we find this in lab work, and I go to treat, I expect the progesterone to be of benefit. I expect to give that woman progesterone, and it works because that's what we found in the lab work, and this is where it should work. But when they take progesterone, they say it made things worse. As a physician, this is when we're called to do our best and try and understand that woman at another level. So that's what this series has been about. This is what I'm trying to understand with these women. I'm trying to discuss with them, like, well, this is what we're looking at. This is what we see. This is how we want to approach these cases. Because you just because progesterone didn't work for you doesn't mean we shouldn't be trying. One, to understand you. Two, not just to understand you, but to give you viable options that will work. So that's what this is all about. The first question is not about that, though. I build you up and I let you down. No, it's not letting you down, but this is important. And this question was brought up. It's specific to how you metabolize hormones when you have MTHFR. So I'm going to bring this one in because this was good. And this was a question by Hope in Sunsets. And she writes, what do you recommend for adenomyosis in perimenopause with someone who has MTHFR and doesn't detox hormones well? Why is this a good question? The reason why is that when estrogen is in your body, it has to do its job. So your ovaries release estrogen, they do their job, they go to all the tissue and they bind to it and stimulate things to do as they're supposed to. The line of the uterus becomes a little bit thicker, more collagen, better bone density. It does a lot of stuff, estrogen, brain chemistry, body. It's very good for you. You need it, but it needs to be in balance. Part of maintaining that balance of estrogen in your body is the way it's metabolized out of the body. So estradiol does its work the first 2 weeks of the cycle, generally is when it's dominant, and then it should be metabolized out. What does that look like? And how does that go wrong? This is what the question is primarily about: detoxifying hormones. Estradiol, if you don't metabolize it very well, your liver doesn't do a very good job eliminating it, sticks around in your body, and it'll be the version of estrone, which is more largely inflammatory type of estrogen, and that sticking around is not very good for us. It has a lot of adverse implications on our health long term. It's not very good for breast tissue. It's just overall, it's an inflammatory estrogen. When someone has the MTHFR deficit, when they have a genetic disorder, and many of us have it. It's not the end of the world, but it is very important to treat it. But MTHFR is important because it's when you eat food and there's folate in your food. Folate by itself does nothing. It has to be brought into your body, then your body has to add something called the methyl group onto it. It has to activate it. So it has that methyl group onto the folate. Now it's methylfolate. Now methylfolate can work. Someone who genetically does not methylate their folate will always have a low grade or high grade folate deficiency. And that can appear in many different ways for many different people. One of the ways it shows up is your ability to metabolize estrogen in a healthy way. Estrogen gets metabolized in your liver, and there's 2 stages to it. The first stage is going to be hydroxylation, and that's when we add a hydroxy group and we make that compound water soluble. The second stage is going to be methylation, so we add a protein group onto it, and that's when the final stage after that is elimination. Methylation is not really where you see the problem. So you think, oh, well, it's methylating the estrogen. No, that's not quite it. You actually, in order to hydroxylate your estrogen to get it moving outward, you need a fair amount of methylfolate and methyl B12. You just need that methyl group added on there. So with someone who has the MTHFR, a lot of times they don't move the estrogen the second step. They'll get it just in there. It's estrone, but it doesn't quite move along. So in those cases with those patients, you give them methylated folate. I've asked Evelyn to put this little metabolic pathway. This might be easier. And if you look at this metabolic pathway, I'm looking at the metabolic pathway now, so I can make sure I word this well to you. You'll see that in the far corner there is going to be where your estradiol is, and then estradiol turns to estrone. Estrone, then you see that phase 1 is hydroxylation, and that can be influenced by diindolylmethane. That's what DIM, we use DIM a lot of times to induce that first step in the detoxification pathway. And then you see underneath there, you see that L-methionine. That L-methionine SAH pathway there, right? That wheel, that circle there, that gets turned by the 5-MTHF or methyl tetrahydrofolate. That's the active version of folate. And you see there's vitamin B12 there, vitamin and methyl B12. That's part of the pathway as well. You see those 2 in there. And then you see there's TMG and choline. TMG is trimethylglycine. And that's something that you find in a lot of supplements. We use that something called homocysteine supreme by a company called Designs for Health. Again, I have no affiliation with them, but they have methylfolate, they have methyl B12, and they have TMG in that supplement. So I use that a lot of times because I know I could trust them. And when I run my labs, I know it did a good job. Other things you see in here, look there in the corner, you see there's B6, vitamin B6. When we use vitamin B6, I don't use just plain pyridoxine. I use something called pyridoxal 5-phosphate. That's a safer version of vitamin B6 to use. I'll use 50 milligrams of that. And then you see over on the other side, there's magnesium playing a role with the CalmT. So when someone tells me they have MTHFR and they want to know how they can help metabolize their estrogen a little bit better, this is what I'm looking at. This is what I'm doing. Adenomyosis is, that's when the endometrium is growing into, the myometrium is growing into your muscle layer. And very painful. And again, it's just estrogen driven more than anything else. You know, there's other factors, but really we need to make sure we're being aware of your estrogen metabolism. And a woman who's perimenopausal tends to have elevated levels of estrogen, and they're not ovulating very well. That estrogen dominance will exacerbate that adenomyosis. So it's very important that I work very hard to help them metabolize their estrogen well. Lab work supports what I do, and these pathways work well. Provided that you don't have a problem as a reverse responder to progesterone, I'll then also use progesterone with you in the second half of your cycle, so we hopefully will have it cycled for you. And that's the way I approach this with people with MTHFR. The only way to know it works, really works, is running lab work to verify. This is an important thing that I do labs for because it's good not to guess with too much estrogen in the human body. If estrogen is not being metabolized well, it's important for us to know that and do our work to figure that out. So I'd always use this with lab work. But that's pretty much the protocol that's worked well for me over the years. This is Science Siren 77. And which I love your guys' names, the handles you use or monikers you use are awesome. So Science Siren 77. wrote, what if your symptoms aren't neurological but physiological? Anytime I've ever tried it, either in birth control or singularly as BHRT, it causes bloating and immediate weight gain, like 20 pounds, not 2 to 3 pounds. I'm post hysterectomy, so it isn't worth the inflammation, increased cholesterol, increased blood pressure, and pushing me into prediabetes once that weight goes up. I want you to know that is not a normal response, and it is valid for you to be concerned. And even if we just say, okay, well, just don't do progesterone, I want you to know that's not good enough for you, not for you and I, not for what we want. We want better care. Why is it doing that? Why not figure it out? Why I don't, I'm saying this because I just got out of the room with another patient a moment ago. And, it's funny. When I was really young, this stuck in my mind. My parents had their friends over, and I remember my mom's friend saying that she went to the doctor, and she told the doctor, I can't raise my shoulder past here. I can't go any higher than that. And the doctor says, well, just don't raise your arms any more that higher. That was the medical advice. I don't know why that stuck in my head to this day, rent free. Progesterone acts as a potassium-sparing diuretic in your body. Progesterone, bioidentical natural progesterone, not synthetic, but natural progesterone, should have the exact opposite effect. And when it doesn't, physiologically, I need to know, you and I need to know. Now, Science Siren 77, you strike me as a very scientific person. And, when our minds work that way, we want to understand you, right? So think about this. My concern with reverse responders is that when we give them progesterone, it converts to allopregnenolone, and they're having an adverse response to allopregnenolone neurologically, right? So we know there's something going on there. There's a few different things we discussed that could cause that. Okay, that's there. Progesterone along that pathway plays a role with that aldosterone. If you look at your metabolic pathway, Evelyn, if you want, I'm putting that up there, you'll see it in here. If you see this metabolic pathway, you see how progesterone is here and how it runs further down the road, and you see how it plays a role in the production of aldosterone. So when you have the exact opposite response, it's important for you and I to sit down and run labs and understand you. I'm not saying I know exactly how this works, but I will say that every time I've had a case like yours, it's been something different than progesterone. So I'd want to run lab work with you. I'd want to understand your aldosterone levels, your cortisol levels. I want to see what kind of progesterone you're getting, because I'm not, doubting you ever at all. I never do. I never do. Never will doubt. Never doubt a patient. When a patient comes in and tells you this is what they're going through, last thing they need you to do is doubt them. You know what I mean? So I'm not doubting it, but I am saying I want to have eyes on what was being prescribed to you and understand it. I want to see what was in it. This sounds weird too, but I'll say it anyway because might as well. I've had patients where they took hydrocortisone orally from one brand and had one reaction, and took it from another brand and had a completely different reaction. And I remember all the pharmacists saying, that's not possible. It's not possible. And after you do your homework, you realize not only is it possible, but it happens, and it's been shown in the literature to happen. So I'd want to know what version you're getting, what additives were in there, and what your response was. I mean, if you're getting prometrium, for instance, prometrium has peanut oil as its source. So I want to know, is a part of this is peanut oil? Is this possibly allergenic component? I want to know. So it's the chances of it being progesterone in and of itself is not, it's not as likely as it is a other factor. That doesn't mean we should not try and understand how you may be responding to progesterone differently, but I still want to be smarter than just saying don't take progesterone. And I want to be smarter to understand what the biochemistry is underneath it, so that we can understand you more fully. As a half answer, I think, because it just means I need to look more into your case, but I want you to understand why I'm saying that the approach needs to be more broad, and you need a lot of thought. You deserve that. So I hope that helped. If it didn't, I'm right here. I will always do my best to be helpful in these situations because this should be the opposite for you. So thank you for writing though. So this is from Helga Pure Karen, Per Karen, and she writes, I take vaginal progesterone about 2 weeks. Um, it was horrible orally. I know oral probably should give more benefits, but I just can't. I tried over and over to be sure that the progesterone was making her feel that way. And I'm testing most of the times different ways. I tried it on my tongue. That was the worst. Sleepy in 10 minutes, but during the night, it was awful. Many wake ups, unbelievable nightmares, and all my real fears in life became my dreams. Underneath that, you see a few more people chimed in. They have a similar response. Switching to vaginal really helped these people. Um, when you take progesterone in orally, it has a higher rate of conversion to allopregnanolone. And in the episodes I mentioned, some women have an opposite response to allopregnanolone. There's a couple different reasons for that. Sometimes it's just that the allopregnanolone should be in a tight window, and when you do it orally, you're gonna have way more than normally present, so you kind of have a reverse response. It's not the fact that your body responds to allopregnanolone wrong, meaning if allopregnanolone is in the normal range, and we give it to you, if it goes way above that, that could be a problem. So taking it orally, that's possible. Other cases with people is that there's something going on with their allopregnanolone. The receptors in the brain don't really respond to it really correctly. There's some issues around that, and that is a concern. But no matter what, when you take in oral progesterone of any kind, you have that bump up in allopreg, and that's going to cause that side effect. Transvaginal is good. Also, a rectal suppository is another. It's actually better if you're sexually active. I recommend doing a rectal suppository instead. We don't have a ton of research on the impact of topical progesterone to a man's penis, but it is a worthwhile thing to be considering because you don't want to spread hormones on other people. So transrectal would be a better option, I believe. With that said, still, it's you get transvaginal or transrectal, you're going to have the same benefit to protect the line of the uterus. You're going to have the same benefit to protecting breast tissue. You have that same anti-estrogen effect. So that is not a bad route, and that does work. So I hope that's helpful. So this is by Kathy B. And she asks, your thoughts on using progesterone postmenopausal with previous hormone-positive breast cancer? No oncologist will have this discussion. So many benefits to progesterone. Sadly, this subset of patients is at a total loss of any benefits of any kind of hormone therapy, even vaginal estrogen, plus so many systemic negative side effects from the aromatase inhibitors. I want you to know that the prohibition against hormones to prevent breast cancer, one is not correct. We've already discussed that. Bioidentical progesterone, bioidentical estrogen, these things do not have a causative effect. So when we do hormone replacement therapy, it doesn't. I know that's not your question. I just want to word that out loud. We know that women who are survivors of breast cancer, who are estrogen receptor positive, I have the conversation with their oncologist. And I recommend, if it's just estrogen receptor positive, I do recommend progesterone. And I do use progesterone in those cases. I don't think they're being, that doesn't preclude them from using progesterone. It doesn't, actually. There's nothing that says it does. So I always prescribe progesterone in those settings. Further, testosterone is a very important tool to use in those cases of estrogen receptor positive. It's an incredibly important tool. Testosterone, again, it's important to know this. Testosterone manages many of the side effects of low estrogen that women have, aromatase inhibitors, because they've had estrogen receptor positive breast cancer. So a lot of these women are going to be having hot flashes, night sweats, vaginal dryness, urinary tract infections. They're going to have, bone loss. They're going to be having hair loss. They're going to have collagen loss, memory, mood disruption. All of these things happening to them. All of these things, testosterone will help. So prescribing testosterone to that population is actually one of the most important things we do. Now, if they have estrogen receptor positive cancer, and you're looking at your biochemistry, you say, well, Brendan, if I give them testosterone, it's going to aromatize to estrogen. They're still going to get estrogen from it. Yes, but if they're on an aromatase inhibitor already, it won't because it's not. You run your labs to verify. This type of medicine requires someone at the seat driving, not someone putting you on autopilot. This is why you have so many doctors not wanting to have the conversation. Medicine is broken. Medicine is broken. And doctors don't enter the room and use this anymore. They use a playbook that they were told to use. They don't talk biochemistry anymore because they didn't have to do it anymore. They're losing that skill set. So when you go talk to them like this, they haven't spoken like this since med school, some of them, most of them. And now they're only using what they're told to do. Sadly, this is the state of medicine. I think it's important to find doctors who are still practicing medicine, who sit down with you and treat you as an individual woman and see you more than just a person they click through their boxes and get their check from the insurance company. There are so many women that I've seen who are cancer survivors and continue to see, and they thrive. They thrive. Having breast cancer and being a survivor of breast cancer is something that you should be celebrated for, and that your support team, meaning physicians, care providers, should work as hard as humanly possible to improve your quality of life to be the best possible. Because when you go through something that profound and survive it, you deserve something to celebrate. And that's a life that's beautiful. So that's something I feel very strongly about. The next one is you mentioned breast health and progesterone. I'm a reverse responder and taking very low doses of oral bioidentical progesterone while using estrogen, testosterone, and DHEA after a full hysterectomy. Will imbalanced progesterone, meaning too low of a dose, cause breast tenderness? I'm so confused and really don't know where to find clarity when my doctor has no answers. So this is from Laura Lee Adams. Laura Lee, this is a big one. And I want you to know I see you, and this is a good thing to talk about. Yes, not enough progesterone will cause that. But it's a combination. It's estrogen here and progesterone being here. That's when you have that problem. We want your progesterone being here. So, transvaginal, if you're not sexually active, if you're sexually active, a rectal suppository is a very, very useful tool. And then we run your lab work. Now, if you're menopausal, we want your progesterone somewhere around 5 month long. That's a good number. All month long, around 5. That's a great progesterone level. And then we want your estradiol. What's the least I need to use at the end of the day? If you're doing, estrogen, so estradiol for me on a lab, 82 in the literature shows benefit to bone. Okay. So 82, if they're not losing testosterone, I'm going to push the estradiol towards 82 and make sure they're maintaining bone density. But if they're using testosterone also helps with bone density. So I can use less estrogen. Sometimes we'll use someone's estradiol and the lab work will come back in the mid 30s or 40s, as long as you're not having side effects, breast distension, of course, hot flashes, night sweats, vaginal dryness, urinary tract infections, all those things that show low estrogen. I'm fine with your estradiol being at 32, and then that progesterone, around 5. That's a great balance right there. So I hear you that you, as a reverse responder, you can't do high dosing oral. So this is a better way of doing it. So try that. And you should never settle for breast pain. No woman should ever have breast pain. Every month you have breast pain, that means your estrogen is overstimulating tissue without having progesterone inhibiting that stimulation. If you stimulate tissue over and over and over again, at what point will the cells duplicate inappropriately, leading to pathology? That's the question. And why even try figuring that out? Let's just not let it happen. No more breast pain. It's breast pain in clinic is not, it's well managed. when we balance the estrogen and progesterone in these women. So I very strongly believe in that. And women, whenever they have breast pain, it's one of those things I don't think you guys should settle for it. I think it's something we should be very aggressive at treating at the clinical level, in my opinion. So I hope that helps. Changing the route of delivery to transvaginal, if you're not sexually active, or a rectal suppository. Those are good ways of doing it. The lab work will be shown that it's effective absorption for you. 1 to 200 milligrams suppository is a very effective dose. So try that. All right, Jan Art 33. Love this question, Jan Art. Hi, Doc. When you get time, can you give your thoughts on high sex hormone binding globulin with low free testosterone? I struggle with that constantly. Doc said higher T, but that has caused too much facial hair. I need more free T. Okay. Two things happening here with Jan Art, so let's talk about it. One is that your testosterone that happens in your body, either their doctor's prescribing it or you're making it yourself, it just comes out into circulation. Now, testosterone initially is going to be bound to that protein called sex hormone binding globulin. Think of that as like a little magnet, and it pulls off all the metal around it, just holds it on that magnet. And so sex hormone binding globulin holds it there, and then slowly some of it peels off. The free part is what's peeled off. That's free testosterone is free to bind to tissue and stimulate it to grow and be more healthy. Great. So that's how it does its work. There's a thing to this, though. Sometimes your sex hormone binding globulin, the magnet there, is too big, and it sequesters all the testosterone. So your total testosterone is bound to that protein, and your free testosterone is very low. Someone looking at your lab saying, oh, you have plenty of testosterone. Yeah, it's bound. It's not working. It has to be free. This is what's important. So this protein, it's very important that we understand this protein. This protein becomes elevated in women most commonly when they've had exposure to oral estrogen over time. Oral contraceptives does that. Oral estradiol of any kind does this. It causes your liver to overproduce that protein, sex hormone binding globulin. So when you have a high sex hormone binding globulin, you're not going to have very much free testosterone. That's a truth. How do you get it to go down? One is make sure you eliminate any oral sources of estrogen out of your life. Go towards a different delivery system. That's one. Two, if it still stays high, I've had great success using DHEA as an over-the-counter supplement. We start at 25 milligrams, which I know sounds maniacal. It seems like a high dose. It's a high dose, but the impact it has on the liver's production of sex hormone binding globulin is proven. I've seen it again and again. I've tried boron. I've seen the literature. Boron is popular. Never seen it really work clinically. So I stick with the DHEA because I have good success there. So I give them DHEA, and I watch what it does to sex hormone binding globulin. Sex hormone binding globulin, that protein, should get smaller. And the free testosterone should go higher, and the total testosterone should go lower. So you're liberating more of that testosterone off the protein to be useful. That's really important we get that part set. Why on earth would a woman, here's my next part. There's two parts to your question. You didn't even know it. Second part of your question. Why on earth would your testosterone, when it's total bound to protein, right? And there's very little free, why would you have side effects of facial hair? Why would you have side effects? Where do they come from? What happened? When that testosterone is bound, you can have like a 300, 400 total testosterone. If it's bound to protein, it's going to do nothing. You won't feel it. It won't even cause any side effects because it's stuck there. What causes side effects is when testosterone goes into the cell and it gets bioconverted in the cell into dihydrotestosterone. That's where that happens. So for you to have side effects, there has to be more dihydrotestosterone than you know. The dihydrotestosterone in women should be below 20. Some lab companies say below 22, below 20. Anyway, 15, that's a great number. 18, great number. Starting at above 18, you're starting to flirt with side effects. So when you come into clinic and we run these labs, if you have your testosterone is all bound to protein, so you have a high total, 0 free, and you have a high dihydrotestosterone, I know that some of this total, it is getting free, but when it gets to the cell, it gets hyperconverted to dihydro. So those women have a fast conversion of testosterone to dihydrotestosterone in the cell. I'll see that in the lab. So I need to now manage the dihydrotestosterone. We use things that will inhibit, it's called 5-alpha reductase. That's the enzyme pathway that converts testosterone to dihydrotestosterone. We want to inhibit that. Saw palmetto works well. There's other ways of doing it, but this is saw palmetto. Those are things I could do to manage that. I avoid using pharmaceuticals like finasteride or Propecia because so many side effects, because it shuts down this enzyme pathway too much. You need some conversion. You just need to slow it down. So getting in there again with saw palmetto, even pumpkin seeds, believe it or not, that works well too. So that's one part of it. Another part of it is it's the fact of life. If you're married, look at your husband. As a man, I will tell you this is a truth. As we go through life, men are more obvious than women, but as we all go through life, we become more sensitive to dihydrotestosterone. We grow hair in weird places as we get older. And I was like, why am I growing hair all over? It's part of, as you get older, your body becomes more sensitive to dihydrotestosterone. So your dihydro may even be normal, but because your body is becoming more sensitive to it, even at the low levels, you're going to see these side effects. So it's important to kind of assess the dihydro and see if it's pathological. Is it supraphysiological? Is it above 20? I need to lower it. Is it part of that pathway of your testosterone? I need to fix that. So the two things we're looking at, one is on the cellular level with the testosterone through sex hormone-binding globulin, DHEA to help change that, using lab work to verify it worked. And then on the other end, what's your dihydro output? Are you hyperconverting to dihydro, or is your free? Like what's going on there? So I want to run that dihydrotestosterone lab and see where that number is too. If you're doing topical testosterone, that will always, 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 always cause you to have more dihydrotestosterone. Topical testosterone will always cause high dihydrotestosterone. So if your doctor's giving you topical testosterone with this, and your total is high, your free is low, but you have a lot of side effects, it's because they're giving you a topical. It's causing this. So switch to either injectable or an injectable version. One of those three. Honestly, the only one I know that works well when it comes to avoiding dihydro is injectable or pellets. But pellets, it's a 3-month commitment, 4-month commitment. Once it's in there, it's going to be stuck there for 3 to 4 months. Your doses won't change during that time. So these are things to consider. So I hope that helps. I'm going to make one more episode in this series because I got a lot of other questions here about reverse responding that's very important to get into. I'm going to talk about how when you take in oral progesterone, the first pass through the liver is what causes a lot of you to have these side effects, because I want to talk about that. I didn't really get into that too much, but I realized I really should be more clear. So I'm going to step back into this series with one more episode in the series. After that, I'm going to do a series on testosterone. I think it's time to do a series on testosterone for women. So I hope this helps. It's always a pleasure to be here doing these videos with you. It's always a pleasure to be helpful and useful. And you guys, to the degree that it is, please, comment and let me know. Your comments really do drive content. It helps me understand what you want to hear. And your comments also help me become better at this, because you give me feedback. I don't understand this. What does that mean? Every time you tell me these things, it helps me. And I just want to be good at this because I love doing this. I love it. So thank you so much again for tuning in, and I'll see you at the next episode. Good.